My name's Mark Tomlinson, and I'm going to be presenting my Sustainable Development Goal critical assignment on HIV in Sub-Saharan Africa. The environmental, political, economic, and cultural challenges in Sub-Saharan Africa have created a perfect storm exacerbating the burdens the population suffer from, particularly HIV. It will take a concerted global effort focusing on removing discrimination and targeting key populations to reverse the approximately 70% of the global burden of HIV which is seen in this region. So first I'm going to talk about the history of the Sustainable Development Goals and where they came from. So they came out of the Millennium Development Goals that were established in September of 2000 from the United Nations. Those original Millennium Development Goals had 8 goals, with most of them focusing on ways to reduce hunger, extreme poverty, and disease, with the deadline of achieving those goals by 2015. And then in 2015, they had reconvened in order to look at the metrics from the Millennium Development Goals, and they built off of the lessons learned and the progress they have made and developed the Sustainable Development Goals. So these goals, they had 17 of them, which focused on poverty, hunger, good health and well-being, which is similar to what the Millennium Development Goals had. In addition, they also had a focus on gender equality, affordable clean energy, sustainable cities, to name a few, with a deadline of meeting these goals of 2030. My specific area that I'm going to be focusing on is goal number 3, which is to ensure healthy lives and promote well-being for all ages. And specifically down to target 3.3, this one focuses on diseases. So by 2030, they wanted to end the epidemic of AIDS, tuberculosis, malaria, and also the neglected tropical diseases, along with hepatitis, waterborne diseases, and any of the other communicable diseases that are seen in the world. So the history of HIV. The first case of HIV was reported in 1981 in Los Angeles, California. In 1982, approximately a year later, that was when the first case was reported in sub-Saharan Africa. But researchers actually believe that this disease has actually started back in Central Africa, back all the way into the 1800s, and that it was actually a zoologic disease that migrated from chimpanzees to humans. The chimpanzee disease, which is related to HIV, is the simian immunodeficiency virus. And then, of course, it passed to humans and then slowly spread out to Africa and then into other parts of the world. As of 2020, there are now 37.7 million people living with HIV and an estimated of 1.5 million new infections annually. The majority of those living in HIV are in low to middle income countries, with nearly 70% of the global burden in sub-Saharan Africa. So what is HIV? HIV, or the human immunodeficiency virus, is a retrovirus. So it's actually an RNA-based virus, as opposed to other viruses that utilize their actual DNA when they infect. This particular virus actually attacks the immune system's CD4 T cells, which is actually quite insidious because it's those same cells are the ones tasked to actually eliminate the virus. So it actually attacks what's actually supposed to get rid of this particular disease. There are 3 stages of infection. The first one is the acute phase. And in this phase, this is when someone is first infected with the virus. You typically have flu-like symptoms, fevers, chills, and at this stage, they have a high amount of virus circulating in their body, and they are considered very contagious at this point. Eventually, the body does fight off some of the virus, and it kind of normalizes into stage 2, which is the chronic phase. So in the chronic phase, the virus is still slowly whittling away at the body's immune system, but it is more of a asymptomatic latency phase People can still transmit the virus, and it can take a decade or more without treatment for it then to progress to stage 3, which is acquired immune deficiency syndrome, or AIDS. At this stage, the viral load is very high. The virus at this point has pretty much completely destroyed the body's immune system, and the immune system begins to fail. At this point, opportunistic infections, cancers, other communicable diseases pretty much take hold, and the survivability at this point without any form of treatment is about 3 years. Treatment for HIV has progressed over the number of decades since it was first discovered. There is no known cure. Back in the mid-90s is when we saw the highly active antiretroviral therapy come into play. This particular medications that have come about have helped that in 1997 we saw the first decline in age-related deaths. And then over time, the medication has been expanded into both PEP and PrEP. So PEP is post-exposure prophylactic, and the CDC recommended back in 2005 to use this for people who have been exposed to HIV, whether it was through occupational or non-occupational exposures, within 72 hours to reduce the transmission and acquiring of HIV. In 2011, we saw the CDC come out with the recommendations for the use of PrEP, which is the use of these medications for non-HIV positive individuals in order to prevent acquiring HIV. And then in 2017, there were a number of studies that have come out and shown that those who have been on antiretroviral therapy and have had their viral load suppressed are essentially untransmittable. They cannot transmit the disease to others. And this has had a wide range of benefits from mother to child transmission, breastfeeding, and also just in everyday life. So the main issues which affect HIV in sub-Saharan Africa include poverty, nutrition, access to healthcare and medication, discrimination, and concurrent endemic diseases. The first area I'm going to cover is poverty. In sub-Saharan Africa, 40% of the population live below the poverty line, or approximately $1.90 US dollars per day. This area is 2/3 of the global burden of extreme poverty. The effects of poverty include hunger, poor school performance. Children often do not complete school in order to go work and help to contribute to the family. A lot of times they're taking on low-skilled jobs with poor working environments, poor environmental controls in where they work. They lack clean water, sanitation, they have poor housing, and then just their knowledge of health and what is needed in order to improve their health. With their poor education and everything, they just do not have that good understanding of what it takes to improve their health. So poverty, when it relates to HIV, the prevalence of HIV in sub-Saharan Africa, one of the advantages is it is no longer being associated by income and wealth. There have been studies that have been conducted over the last few years that have shown that there is no direct correlation between the prevalence of HIV and the GDP of the countries within sub-Saharan Africa. And actually, countries with the highest GDP also had the highest prevalence. Wealthy individuals in sub-Saharan Africa, they did show a lower odds of actually contracting HIV than those who were poor, and that countries who had increased their spending on healthcare have shown a decrease in HIV, but it's really only in those wealthy individuals, not in the middle and the lower income areas within the country. However, as spending on antiretroviral medication has increased, most countries are now doing this at no cost to all of their population. And HIV outcomes between the wealthy and the poor, they are starting to trend towards each other. So they're no longer seeing the large disparities that they had initially when the antiretroviral medications first came out. The next area that affects HIV is nutrition. Undernutrition is a big issue within sub-Saharan Africa. There are deficiencies with undernutrition, deficiencies in your macronutrients, which are your proteins, your carbohydrates, and your fats, and then also your micronutrients, which is all your vitamins and minerals. And undernutrition, particularly with the macros, leads to wasting and stunting, and then with your micronutrients, it leads to many other deficiency-related diseases such as scurvy and rickets. And this just overall weakens the body's immune system, its ability to repair and grow. The other issue is with overnutrition, and of course this is consuming too much food, too many calories, and it leads to obesity. Obesity, of course, leads to many other health conditions such as diabetes, heart disease, strokes, cancers, and of course having diabetes and heart disease on top of having HIV just continues to exacerbate the issues. And then in sub-Saharan Africa, a lot of places are starting to have the co-burden of obesity and undernutrition. And this is from getting over-processed, nutrition-poor food with high calories that kind of plague the high-income countries, basically just junk food, just things that are very high-fat, high-calorie, but really not providing any good nutritional value, good vitamins, good minerals. And so the diet-related diseases, of course, are increasing. So that includes your heart disease, your diabetes, but then they're also still getting the micronutrient type deficient diseases on top of it. So they're seeing kind of both at the same time. One of the ways that nutrition can actually be used to help combat HIV is just by taking a daily vitamin. A study out of Tanzania, which showed that patients who were given a daily vitamin along with their antiretroviral therapy, that this multivitamin actually slowed the decline in CD4s. It's helped prevent severe anemia and wasting, disease progression, and also immunologic failure. These particular vitamins, they were rich in B, C, E, and selenium. And overall, it helped to reduce the mortality rate for these newly diagnosed patients. The next area that affects HIV in sub-Saharan Africa is just access to healthcare and medication. In sub-Saharan Africa, there is both government and private spending on healthcare. However, only about $100 are spent annually per person on healthcare. Government-funded services are very underfunded, understaffed. I know here in the United States, we think ours is underfunded and understaffed, but in sub-Saharan Africa, they deal with chronic strikes, doctors and nurses and other healthcare workers who just do not show up. And a good portion of the people who get educated in healthcare are just moving out of the countries. They're moving to higher income countries in order to seek those higher paying jobs rather than remaining in their home countries and providing care to the population that they grew up with. Unfortunately, the demands for healthcare in that region are expected to double by 2050. And there is a growing segment of the healthcare that is going private. Unfortunately, most people in sub-Saharan Africa, they do not have the money to be able to afford that. And even for the government-funded services, there's cost sharing that has been placed on the population, and most people can't even get basic services that they can afford. And even when they need to have those emergency services, they're just out of reach. They cannot afford to even go to a hospital in an emergency just because of the cost. One of the biggest hurdles many people in sub-Saharan Africa have is just access to providers. There's over 170 million people that are more than 2 hours away from the nearest regional hospital, and 40% of the population are more than 4 hours from a large central hospital that has the most advanced care. And just doctors and nurses, the number per person is so low compared to other areas. To give you an example, there's only 1.08 doctors, nurses, and midwives for every 1,000 people. Compare that to the United States, we have 24.8 for every 1,000. And this equates that there's only 17 doctors, 71 nurses, and 20 midwives for every 100,000 people. And some rural areas are even worse, where they only have a little over 5 doctors to cover 100,000 people. The next frontier is access to medication, and particularly antiretroviral medication for both those who are HIV positive and those who are not. So those who are not HIV positive, if they can all get on PrEP or pre-exposure prophylactic, or those who have had some type of exposure get offered PEP or post-exposure prophylactic, this can significantly reduce the incidence of HIV. Studies have shown that PrEP reduces contracting HIV by 99%. And those that are HIV positive, testing is so important. If we can just get everyone tested, and those that are positive, if they can get on antiretroviral medication, studies have shown that an undetectable viral load is essentially untransmittable. So between those that are untransmittable, those that are on PrEP, the incidence of HIV will continue to decline. Many countries within sub-Saharan Africa have been doing well in getting these medications out to their population. Examples are like Botswana and Rwanda. They have gotten close to 80% of people with HIV on ART, but there are still many countries that are still struggling. Nigeria, Central African Republic, they're still down at around 25%. And you can see here on this graph, this is from the World Bank. They have tracked antiretroviral therapy coverage on people living in sub-Saharan Africa. And you can see, even though that antiretroviral medications started back in the mid to late 90s, you can see that it was essentially 0% in 2000. But now in 2020, we're all the way up to 76%. That is, while 20 years is still a long time, they have made significant strides over these last 2 decades to distribute and get people on antiretroviral medication. And one of the biggest issues is discrimination, which prevents those getting on medication and seeking help. The highest risks people and populations, they are not targets for these interventions that the governments are providing. These include sex workers, prison populations, men who have sex with men. These people are falling through the cracks. Also, adolescents, they're also not getting the treatment that they need. Only half of them are as likely to get treatment as their adult counterparts. There's too many barriers for them, whether it's transportation, whether it's fear from finding out that they're gay, or other factors that prohibits them from seeking treatment. Another area of discrimination is just worldviews. So, of course, the Western world that colonized many areas, they still have this view that Africa is a poor, disease-stricken region that clouds everyone's view of what is going on in the countries there. African leaders, unfortunately, a lot of them hold fast that HIV was actually brought into their countries in order to exhibit control, to reduce their population. And a lot of that comes from mistrust during the colonial times, during malaria, when the British were first colonizing the area and they were trying to prevent malaria. they were just doing, they already started racial segregation. They were keeping the native populations away from them. They were doing everything they can in order to protect the British. But unfortunately, they were doing absolutely nothing for the native population, but just pushing them farther and farther away. And so this has created a mistrust between the African nations and the Western world, and the different types of global initiatives that are being done in these regions. There's a lot of mistrust, and it's actually on both sides. And the final area that I'm going to talk about with HIV in sub-Saharan Africa is concurrent endemic diseases. So malaria has a very high incidence rate in the region, and this leads to a very high co-burden with HIV and malaria. And there's been studies that have shown that there's actually a synergistic effect on the symptoms, outcomes, treatment, and drug interactions between malaria and HIV. This co-infection leads to severe malaria, increased viral load of HIV, increased number of the malaria protozoa that are circulating in the blood, increased placental rate of increased rate of placental malaria in pregnant women, which then of course leads to passing malaria on to the unborn child. And then also it just reduces the antimalarial drug effectiveness. And there's just many drug interactions between the antimalarial medications and the antiretroviral HIV medications. So trying to combat this co-burden is very difficult. A lot of times they're going to have to, do kind of a combination of things. They need to be able to prevent malaria for those who have HIV, using the bed nets, using all the different kinds of tools that they have in order to keep someone who is HIV positive from getting malaria on top of it. The other disease that is very common in the region that also has a high co-burden with HIV is tuberculosis. And tuberculosis is actually the highest cause of death among people who have HIV in sub-Saharan Africa. Those who have HIV are at a higher risk of developing active TB and have serious adverse drug effects. So most people who have TB, they typically have latent TB, but with HIV as a co-burden, they go right into the active, which of course then, as with active TB, you're more apt to spread TB. So just the combination of the two just continues to add to that co-burden. So one of the biggest causes or factors in determining if someone is at risk for HIV is actually gender. Females age 15 to 24 in sub-Saharan Africa have 8 times the risk of getting HIV than their male counterparts. And females in this age group, they account for 80% of the global burden of HIV. That is an astounding number for those in that age group. And of course, just the threat of having HIV. Of course, HIV attacks the immune system, it weakens the immune system, and it further causes susceptibility to many infections, opportunistic infections. Someone with full-blown AIDS, then they start utilizing more health care. In that particular region in sub-Saharan Africa, of course, with poverty on top of that, they can't afford care, and so they typically just do not have access and the tools that they need in order to combat HIV. And from a human rights standpoint with HIV, there's so many value judgments that are done. People blame those who become infected, blame them for their own actions that got them infected. And this just further stigmatizes particularly key populations, those who are poor, those who are in the prison system, those who are sex workers, and it just causes them not to seek care. And those, of course, who do not seek treatment, do not seek testing, it only further exacerbates the issue. It furthers the spread of HIV. The whole goal is to get those who do not know their status tested and those who are positive to get into treatment. But if they continue to have the blame placed on them, and they will not do so. So there are many countries including the United States, that are passing laws about HIV. So many countries are criminalizing HIV, so they will prosecute people for spitting, scratching, having sex with condoms, or even those who have undetectable viral loads. And these are all based on myths and ignorance. They're not based on the current science of HIV, of the treatments and the prevention strategies that are available. And this, of course, will just continue to stigmatize and marginalize the most vulnerable individuals. So there are many obligations that many countries have in regards to HIV. There are many pledges that a lot of the high-income countries have made in order to combat HIV, to fund programs for those that are in developing nations. But unfortunately, many of those pledges, they're all declining. Of course, as the cost for antiretroviral therapies continue to increase, many countries, of course, are performing austerity measures, reducing their monetary obligations that they have committed to, and it just leaves more and more people left behind for care. Even the UN's AIDS fast track strategy, it called for 30% of the funding to go to community-based intervention programs. And unfortunately, that funding has only declined since it was announced in 2016. So even though funding has just been pledged, the money is just not flowing to where it needs to. So one of the major stakeholders that's involved in combating HIV globally is, of course, the United Nations UN AIDS program. This program was formed in order to achieve the SDG goal of ending HIV and AIDS and, of course, other diseases by 2030. They're a resource to organize, analyze, and collect data, advocate, of course, for human rights and also for shaping public policy to help remove some of those criminalization laws, to try to help prevent some of the stigma that is going on. And of course, they have their Fast Track Cities project, which came from the Paris Declaration from 2014. And this basically targeted 15 cities around the world in order to try to lower HIV. These 15 cities, of course, had the highest prevalence rate, and 12 of them are in sub-Saharan Africa. The other major stakeholder is actually from the United States. It's the United States President's Emergency Plan for AIDS Relief, or PEPFAR. So this was launched in 2003 as a global initiative to combat HIV. And since that time, they've been able to contribute over $100 billion to many of the programs in order to combat HIV. They are also part of the Fast Track Cities project, and they provide funding and support for HIV, medication, training healthcare workers, and then, of course, providing access to women, children, and other vulnerable populations. And of course, since they know that the community level is where change is needed, PEPFAR has partnered with many local communities and also faith-based organizations in order to dive into those local areas, because the communities and those faith-based organizations, they have trust in the community, and they know that a Western or European organization coming in, there's still going to be that mistrust. So if they can partner with those local ones in order to be able to distribute education and distribute medication, that trust that is there from those organizations will go much further than if they came in and on their own. When COVID-19 began to spread, PEPFAR came in and actually adopted their community-based platforms in order to combat the spread. They knew that they needed to do so in order to protect the HIV population from having a co-burden of both HIV and COVID-19. They knew that these populations were the most vulnerable and that having COVID-19 with HIV would be detrimental. They also use their community-based testing and distribution for antiretroviral therapies. And they found that actually using a community-based platform rather than a clinic-based, so instead of people coming into a hospital, that actually they were able to reach more individuals, particularly men, and actually get their viral loads suppressed. So partnering with FBOs, as PEPFAR does, it has an advantage. Approximately 75% of the population in sub-Saharan Africa routinely attend religious services. And FBOs can reach key populations that would not normally be able to be reached, such as men and children, who typically do not seek care until symptoms are seen. And with HIV, the earlier you can be tested, the earlier you can be on treatment, the better the outcomes. And FBOs can also help the community stand up to sexual violence against women and children, which of course furthers the incidence of HIV. And they can also provide education on new treatments. They can give hope to people who are newly diagnosed. They can educate them that new treatments can actually give them a life of normalcy, that HIV is no longer the death sentence that it used to be, that they can continue to live a life of expectancy as most normal individuals. To give an example of an FBO program, there was one in Zambia, and they were able to identify 12 times more people with HIV than would have normally have gone undiagnosed. They were then able to connect these people to care, and 92% of them had a continuity care after the program. And this model was so successful in this country that they're now starting to expand it into other countries in the region in order to help to identify early and get key populations treatment as early as possible. There are many ethical issues in regards to HIV in sub-Saharan Africa, particularly with clinical trials and research. The first vaccine trials for HIV were started in 1987 in sub-Saharan Africa. These trials raised many questions and concerns. In the United States and in Europe, in order for clinical trials to actually go forward, they have to pass many regulatory boundaries and issues in order to start them. However, they were done in sub-Saharan Africa, and they would not normally have passed those particular requirements to start the trials in those other areas. None of the trials have shown any efficacy whatsoever, and the most recent one, which they thought was going to show promise, they actually had to shut it down because too many of the patients actually had a false sense of security, thinking that they were going to be protected. And so these trials, of course, are still conducted today. All of the clinical trials are supposed to be following the World Health Organization's international agreements, which means that whichever company is actually testing these clinical trials, they have to meet the muster of what is needed if they were actually done in their home countries. So just because they're done in another country in sub-Saharan Africa, they still have to follow the same rules and regulations they would in their home country. The other ethical issues in regards to the patents on antiretroviral medications. Of course, these medications are very expensive, upwards of 12,000+ US per year, well out of reach of anyone that lives in this region, well out of the reach of the countries of being able to even buy the medication and actually distribute it to their population. And there's actually been many lawsuits and international lawsuits that have actually transpired when South Africa actually went and broke the patents on these medications in order to produce them at an affordable level for their population. And South Africa is actually part of the World Trade Organization's agreement on trade-related aspects of intellectual property rights. So this is the agreement between the international countries that basically say that they're going to honor the patents and rights of companies in their various countries that they do business. And with South Africa basically breaking them, of course, the pharmaceutical industries were not happy with that. So, of course, they then filed lawsuits against the government of South Africa. And South Africa actually made the argument that due to the fact that HIV in their area was actually a pandemic, that a pandemic actually overrode those trade agreements. And they, continued to argue, and eventually the pharmaceutical companies actually dropped their lawsuits and allowed South Africa to continue. Um, and they were actually able to afford to give and distribute the medications to other people in their country. They were not the only country to do so. Brazil and Thailand also broke the patents. Of course, both of these are developing nations. And this just goes on to the ethical, conundrum of, whose rights are trump the other, whether it's the rights of the pharmaceutical companies who, of course, develop these medications, or is it rights of the people who are in dire need of these medications? And so that is an ethical issue that still needs to be discussed and worked through. So some last recommendations on HIV, particularly in sub-Saharan Africa. Funding. Countries, organizations, they cannot meet their obligations to their people without funding. They need it for education. They need it for medication. Countries, whether it's the United States, whether it's Europe, whether it's foundations, if they can continue to pledge money to support these countries, they need to continue to meet those obligations. There's no way that a lot of these developing nations have the resources in order to meet the needs of their population, whether it's testing or medication. Discrimination, of course, is by far one of the biggest barriers that's there in order for people to seek treatment. It's also one of the biggest barriers for vulnerable populations. Many people look down upon the prison population, on sex workers, on intravenous drug users. However, without that discrimination, these people can actually not have the stigma and feel that they can go and seek treatment and be able to find out their status. And if they are positive, they can get on treatment. And then that also will lead to a lower incidence of HIV. Of course, significant funding for education needs to be continued to continue to educate people on testing, educate people on treatment, educate people on how treatment can lower the incidence of HIV, because those who are undetectable are untransmittable, which means that people who are in those vulnerable populations will not be spreading HIV, that mother-to-child transmission can be eliminated, people can get on PrEP, so that those also in those vulnerable populations, if they come in contact with HIV, they will not catch HIV. And then countries need to start removing the criminalization laws that they have put in place over the years, and that includes the United States and many countries in Europe, because these laws further stigmatize people. If people know their status, then they feel like they're going to could get prosecuted, get thrown in jail. However, if they don't know their status, then there's no knowledge, so then they just avoid getting tested. So those laws need to be removed in order to remove the stigma and discrimination these people face. And then vaccination. Any kind of vaccination trials that are tested in sub-Saharan Africa or other developing nations, they need to follow international laws. They shouldn't be done by companies or organizations in order to try to circumvent and, just because it's easier in those areas than it would be if it was in the United States or Europe. Countries or companies which are leading these vaccines, when they do these unethical trials, that just foments that distrust that many people in developing nations have of the West and also of Europe, of just kind of coming in and doing what they want. So this continues to lead to a lot of the discrimination, a lot of the mistrust that is seen today. So just some final thoughts on HIV, particularly in sub-Saharan Africa and even just in the world globally. So HIV, of course, is a complex disease, as complex as the host that they invade. There's much stigma from HIVs that has been around since it was first identified. Stigma that it was a gay disease, and that still is perpetuated today. These same biases and stigmas can actually be seen starting anew, just to kind of relate to what's going on today with monkeypox. Monkeypox, like HIV, is being mostly discussed as a gay disease. And unfortunately, history will continue to repeat itself unless we actually study and learn from the past. If we don't make different choices, we're going to be continuing to make the same mistakes. Um, Unfortunately, with kind of what we're seeing, it's kind of sad that we may be making those same mistakes. Viruses and diseases, they don't discriminate, but of course, humans, unfortunately, we continue to do so. And the following slides are the references that were utilized in this presentation.